To be honest, in my personal opinion, there is nothing wrong with me mentally. I am I have a perfectly sound mind, and I think the notion of requiring a requiring therapy beforehand is almost ridiculous.
That's Levi. He's asking you for a letter so he can have gender-affirming surgery. We're mostly going to focus today on why we have the requirements we have for these letters of support for TGD surgery and what those requirements are. First, though, let's start with when. How long do you need to work with Levi before you'll write that letter for him? Where are you on this line right now? Where in this continuum? After 30 minutes? After 5 years? When do you feel comfortable giving a new client a letter of support for gender-affirming surgery? We'll come back to this. I sent out a survey to a bunch of newbie counselors who'd expressed interest in learning more about writing letters for trans and gender diverse surgical care, and here's what I heard back. Most folks just said they didn't know a lot about this. Understandable. Many are anxious about doing the wrong thing. Before we hear from two of these folks, a quick note. Many trans and gender diverse people reach out to counselors specifically for a single session. Their only goal is to get a letter of support for surgery, not to begin ongoing therapy. You'll hear from Levi about this in a moment. Keep that in mind as you hear these counselors' concerns. This person emails me directly to say that a professor had warned them explicitly against offering letters for surgery. In the email, they tell me that although they'd feel okay writing a letter for clients they'd been seeing for a while, quote,
I have a hard time writing a letter for those who aren't my clients. We aren't gatekeeping, but we kind of are, and I'd need a clear picture of a new client's mental health stability before giving them a letter.
this person, and I think there's a lot of counselors out there who share this view, is worried about someone having surgery while not, quote, being in a great place. But were they worried about their client having trouble following aftercare instructions? Did they wish their client had more support, maybe wanted them to work on coping skills or a support system prior to having major surgery? Or, wait, is the counselor worried about their client later regretting having surgery and maybe potentially blaming their counselor for giving them permission to have surgery later on? Then there was this response.
Letters are a byproduct of working hard in therapy, not an expectation from the beginning. Some clients, I believe, started therapy with the intention to get a letter, while others genuinely want to work on themselves.
I'm hearing many counselors are anxious about gatekeeping, about regret, about doing the wrong thing. I get it. Today I'm going to give you historical context and practical tools to help you navigate all of these concerns. Why did trans people end up in this situation? To be more specific, how did this one kid pictured here? His name's Levi. How did he end up looking for a letter of support from a counselor? Just like most of us, Levi probably doesn't think much about the grand movements of history, the evolution of medicine and psychiatry and economics and journalism that are forcing him and us into a particular paradigm. He's thinking about his options and choices. He's not thinking, what would I have done if I'd been born 100 years ago? He's thinking about what he needs right now. He's definitely not thinking about the ramifications of what he's asking of us, his potential counselor. He's just thinking, A, how do I access medical care? And B, how big of a deal is it that I want to do it in the quickest, easiest way possible? Listen to Levi's story and notice what you notice. What comes up in you when you hear this story?
I live in a very small town, very conservative town, and there are therapists here, but because it's such a small community, there really aren't any trans people here. In my immediate area, to my knowledge, I'm the only one. So I definitely didn't feel comfortable taking my gender identity issues to a regular therapist, and there are no gender therapists anywhere around where I live. The closest one that I could have found was about an hour and a half away, and for a weekly or even every other week session, that's still a long way. That means making sure I had to schedule work around it, and it was a lot of unnecessary hassle. So what I ended up doing was I ended up using an online therapist because I needed to get a letter from a therapist in order to start hormones and to have my top surgery. And honestly, there was nothing that was going to stop me from attaining that one way or another. And I'll be honest, doing it online was quicker, it was cheaper, and a hell of a lot easier than trying to find one in person. I've gotten into arguments with, like, my mother, for instance, over... She says I took the easy way out. Maybe I did, but I don't really care, just because, to be honest, in my personal opinion, there is nothing wrong with me mentally. I have a perfectly sound mind, and I think the notion of requiring therapy beforehand is almost ridiculous. I can understand to the point if I can understand the therapy if, well, to make the person realize that these changes are irreversible, and to make sure that they're sure about what they're doing, because I mean, some of the changes aren't irreversible, but surgery is a huge step, and it's not something you want to regret afterwards. And there are things like your voice and stuff like that that are irreversible, and like I said, you don't want to regret those things, and I guess in that way therapy is good. But yeah, but for me, I don't think the therapy was necessary, because I knew what I was, I know who I am, I knew what I wanted, I knew what I needed, and I just needed a letter from the therapist to get what I needed and wanted.
What is Levi asking of us when he asks for a letter of recommendation for surgery? He's asking us to see him and to believe him. That's it. That's the whole thing. So why does this feel complicated? Where did all these other requirements we're worried about come from? And why are we responsible for these letters in the first place? Let's talk about what led to this situation. I'm going to rattle through a bunch of names over the next half hour toward explaining this. All these people are part of the story, but this list is far from comprehensive. The larger history of trans healthcare in the West is just far too big to include everything here. The big takeaway, spoiler, is this. The reason counselors are in charge of signing off on some people's surgeries but not others is just the same as the reason for most things in life. Because a handful of people who happen to be power adjacent decided that's the way it should be. The system we have is the outcome of a bunch of people from a lot of different contexts doing what they thought was best for their careers. Here's what I'm asking you to consider today. The gatekeeping practices many of us use when assessing trans clients for surgery, months of therapy, intrusive questions, the requirement to prove themselves, where did those come from? Most weren't designed by trans people or even by people trying to help trans people access care. They were designed by doctors protecting themselves from liability, by researchers with harmful agendas, by systems that saw trans identity as pathology. Today I'm going to show you that history, explain current standards of care, and offer practical guidance for affirming assessment. You might leave here with different boundaries than you came with, you might not, but you'll leave knowing the history behind the system you're operating in, and you'll be making conscious choices rather than just following institutional inertia. Let's start with that history then. Binary trans people, as well as genderqueer, gender nonconforming, gender fluid, and non-binary people have throughout history modified their presentation and their bodies to be seen as themselves, just as cis people have. There have always been trans people. There will always be trans people. It's important you have a little knowledge about the history of gender-affirming surgery. Without that context, what you're being asked to consider doing is just paperwork with scary legal ramifications. So we're going to tell you a little bit about the lives of some of the pioneers of 20th century surgeries in the West. Some of these stories are hard, and there will be transphobic discourse here. But let's start with what's important, the things that are more than skin deep. Look here and you'll see that behind some wonderfully exotic hairstyles and shockingly janky dance moves, there's confidence, there's community, there's belonging, and most importantly, there's trans joy. This is a video from 1919, and this is a video from 1967. These folks are having fun. This is the first person in the Western world that we happen to know about who had a practicing physician perform gender-affirming surgery on their body. This is Dr. Alan Hart, radiologist and author. In his will, he asked that all his photographs and letters be destroyed, so aside from his public work and writings, we don't know much about him. What we do know is that his Wikipedia is primarily a record of all the places he moves to, because he moves a lot. After being outed by a former classmate, Dr. Hart leaves California. He moves to New York, Illinois, then Pennsylvania, then Seattle, then Idaho, then Connecticut. He and his wife keep moving whenever his history catches up with him. Remember that a trans person's life can be defined by how often they have to move. We'll see this pattern again. At 27, just out of med school with top honors, he obtains a hysterectomy and a legal name change. He marries twice and leads an active, community-aligned life. Here's what else he does with that life. He becomes one of the first doctors to show the progression of tuberculosis using X-ray imaging, which leads to widespread early screening programs. In the late 1930s, he's hired as Idaho's tuberculosis control officer, training staff and conducting mass screenings. It's likely he saves thousands of lives. Similar programs based on his ideas spread to other states, saving countless more lives. It's easy to imagine a scenario in which Dr. Hart isn't able to legally change his name, wear his clothes and hair as he likes, and to obtain his hysterectomy. Instead, his government could have forced him to live as a woman. I'm telling you this story about a guy you've probably never heard of, in part because he is inspiring, and also in part to remind the selfish parts of us all that everyone loses out when one person is impeded from their potential. While Dr. Hart was saving lives in the United States, something remarkable was happening in Berlin. This is a photograph of the world's first clinic that provided gender-affirming surgery for women. The founder of the Institute for Sexual Science, Magnus Hirschfeld, is among the first 20th century Western physicians who support transgender patients. The Institute supports trans people by working to dispel the idea that trans people can become happily cisgender via psychoanalysis. When postoperative patients find it hard to find understanding in the outside world, the Institute finds work for them inside. During the brief period here, Weimar Berlin is advertised to be the capital of the free-thinking world, the city without sexual hang-ups. Think cabaret. They look fun, don't they? This is 1933. This is what became of the Institute for Sexual Science. Medical knowledge is not inevitable. It has to be funded, protected, and passed down, and it can be destroyed. After the Institute burned, all this knowledge could have been lost forever. But in London, this is the first man known to have a phalloplasty, and the first woman known to have a vaginoplasty. Both surgeries were performed by Dr. Harold Gillies, who invented modern plastic surgery while reconstructing faces blown off during World Wars I and II. Michael Dillon was born into an aristocratic family, and that privilege gave him access that most trans people simply didn't have. He's among the first people to use hormones for gender-related reasons. He's able to pay for the 13 surgeries that Dr. Gillies attempts, experimenting as he goes, toward creating the world's first phalloplasty. Michael next qualifies to be a physician and publishes a book in which he writes,
"Where the mind cannot be made to fit the body should be made to fit, approximately at any rate, to the mind."
It's Michael's book that attracts Roberta Cowell. She writes to him, and he falls in love with her. She thought she was the only one. Michael, while still a medical student, performs her orchiectomy, and then asks her to marry him. She doesn't love him in the same way, though she is grateful to him for showing her that this life-changing surgery is possible. When Roberta outs herself to the press for much-needed funds in 1954, the Daily Telegraph notes that publicity from her case brought forward an astonishing number of people seeking similar operations. One British doctor reported 456 demands. People on the margins have always looked for others like themselves. They built networks, shared what they know, and helped each other survive and access care, especially when institutions exclude or fail them. And then everything changed. This is Christine Jorgensen, the first American woman to announce her orchiectomy and penectomy to the world. And this is Harry Benjamin. He'd been friends with Magnus Hirschfeld from Germany's Institute for Sexual Science since around 1907, and he worked with Alfred Kinsey in the 40s. Harry Benjamin finds that treating his girls with estrogen works well to improve their relationship with their bodies. He becomes known as a doctor who treats trans people with respect, affirmation, and hormone replacement therapy. Christine Jorgensen asks Harry Benjamin to be her hormone provider, and he agrees, and also connects her with a surgeon for her penectomy in 1952. Christine Jorgensen makes Harry Benjamin famous. Harry would write in the preface to her autobiography, quote, "Indeed, Christine, without you, probably none of my success would have happened. The grant, my publications, lectures, etc." Christine Jorgensen makes the idea of a sex change suddenly possible to millions of people. She chose to be public about her choices in order to create, quote, "as much good publicity as possible for the sake of all those to whom I am a representation of themselves." After surgery in Denmark, she writes to friends, quote, "As you can see by the enclosed photographs, I have changed a great deal, but it is in the other changes that are so much more important. Remember the shy, miserable person who left America? Well, that person is no more. And as you can see, I'm in marvelous spirits." After the recuperative period, she flies directly home to America. Although the Danish royal family also happens to be on the same airplane, the press leaves the royals alone and swamps Miss Jorgensen instead.
Christine Jorgensen, who used to answer to George, creates quite a stir as she returns home to New York from Copenhagen. Christine hit the headlines following the series of operations in Denmark that transformed her from a boy into a girl.
I'm very impressed by everyone coming.
Christine, are you happy to be home?
Yes, of course. What American wouldn't be?
Have you been offered a movie contract?
Yes, but I haven't accepted it.
Do you have any plans regarding the theater?
No, I don't think so.
Are you going to go on with your photography?
I hope so, yes.
I see.
I'm
Okay,
very happy
quiet.
to be back, and I don't have any plans at the moment. And I thank you all for coming, but I think it's too much.
Speaking of trans joy, back home, Jorgensen launches a successful nightclub act and brings that act to college campuses around the nation. One of her most famous numbers is "I Enjoy Being a Girl," in which she does a quick change into a Wonder Woman costume. She also pens a best-selling autobiography that's adapted into a movie in 1970. Here's a candid of her from that premiere. What a cutie. So that's how it became possible. Pioneers proved the surgery could be done, and that trans people could live full, joyful lives afterward. Now the question becomes, if you're a trans person in the 50s who's just read about Christine Jorgensen in magazines, how do you actually access this life-changing surgery? By the mid-1950s, millions of people know gender-affirming surgery is possible because of Christine Jorgensen. But knowing something exists and being able to access it are very different things. In the entire Western world, there are maybe a handful of surgeons willing to perform these surgeries. Most surgeons are terrified of being sued for criminal mayhem, a felony charge for intentionally disfiguring a body. Most surgeons require extensive psychological evaluation plus months or years of gatekeeping. So what are your options? Option 1. Have money, travel to a surgeon who won't ask questions. This is Dr. Georges Bourou. He's a French surgeon in Morocco who invents the modern penile inversion technique and performs 800 vaginoplasties between 1956 and 1987.
I don't transform men into women. I transform male genitals into genitals that have a feminine aspect. All the rest is in the patient's head.
When you think about the past and current moral fervor around trans healthcare, that Dr. Bourou was ready and able to do this job for 4 decades is pretty striking. Most surgeons in the middle of the 20th century are terrified of a patient wanting revenge for a bad surgery and suing their surgeon for criminal mayhem. But Dr. Bourou doesn't ask questions. He treats vaginoplasty the way that most surgeons treat breast augmentation or rhinoplasty for cis women. He does show surgical candidates photos of the gory process of vaginoplasty to see if it's something they really want, and then asks if they still want it. If you could save up $2,000, about $24,000 in today's US dollars, and critically, if Dr. Bourou thinks you will pass following surgery, he'll operate tomorrow. This is April Ashley. She's the starlet here who keeps looking into the camera. She's a British teenager who was discharged from the British Merchant Navy at age 16 following a series of sexual assaults by her fellow sailors, which led to a suicide attempt. She moves to Paris and becomes a successful fashion model and nightclub act. She's in Vogue. She's in this Bing Crosby Bob Hope movie, age 27. In 1960, she travels to Casablanca and has surgery with Dr. Bourou. Look at the smile on April Ashley's gorgeous mug. I fucking love her smile. What do you think she's communicating here? Because I think she really likes herself and wants to make sure that we see that too. We wouldn't know April Ashley was trans if a friend hadn't outed her to the press for an extremely small amount of money just a year after her surgery. Her budding acting career was immediately destroyed and her modeling career was tanked. But thousands and thousands of trans people write to her over the next 5 decades, and she answers them openly and with kindness. This is the cost of visibility. Your story and your face become public property. Christine Jorgensen embraced her public platform. Michael Dillon fled to Tibet to escape his brush with infamy. April Ashley went on to become an advocate for transgender rights, eventually appointed a member of the Order of the British Empire for her services to equality. Her outing, her visibility, created hope for others, offering solace and inspiration for those who so long believed they were the only ones. But what if you didn't have $2,000? What if you couldn't afford Morocco? Option 2, make do however you can. These photographs are by the Swedish photographer Christer Stromholm. They are of trans women he knew in the 50s and 60s in Paris. The photographer wrote of
Meeting young people from all over the world who gathered in the city to seek comfort, shared feelings, friendships, and their feminine side. Most of them weren't understood, so they fled their homes and often hostile families. Here, they could live their conviction of being a woman, that draw on their self-confidence, take steps to consider an operation and change their lives, become a hairdresser, a shop assistant, a nurse or a student. But before that, everything had to go well in Casablanca.
The photographer continued.
It was in the late 50s that the word transsexual began to be used. It was also at that time that it became possible for a man to physically become a woman, thanks to hormones and surgery. But often they were denied the help of a doctor, so they had to fend for themselves. Sometimes they dealt with difficult problems, the consequences of which could be irreversible or fatal. Incorrect dosages, suicides. My friends could not find work. An ID card was necessary, and if the name did not fit the feminine appearance, any job became an inaccessible dream. There was no social security, and society's unwillingness to understand made life impossible. This cost them dear. Common sense does not accept playing with identity. The state pushed people into prostitution, even though it pretended to fight it.
When I listen to the photographer's words, I'm reminded of the gravity and unfairness of the society surrounding these women. When I look at Stromholm's photographs, however, it's impossible for me not to notice the glee on their faces, the satisfaction with themselves and with their friends and lovers. In this picture, notice the prim woman on the far right cheating out her legs to show off her gams, or the woman in the middle, her hand on her hip, slouching with an expression like, yeah, what? My favorite, though, is the woman on the far left. She's talking with her friends. Why are you bothering her with this camera? She turns her head barely and waits for the picture to be over with so she can get back to what matters, back to her life. For people without money, the path could be dangerous. DIY medical care, sex work to try to afford Morocco, or nothing. And yet, community, joy, life. Option 3. Wait for America to catch up? By the middle of the 20th century, there was a new era in which people had more access to medical treatments, as long as they could afford those. Some were able to live vastly freer lives because of the possibility of gender-affirming surgery. For those born without money, the road was much harder. But what if you happen to be so rich that your money could literally change the world? What if you happen to be born Reed Erickson, one of the coolest people ever? First, of course, you write to the most famous trans-friendly person you can think of, and you ask for his advice on obtaining surgery. As soon as Reed's millionaire father dies, he quickly takes the opportunity to write to the famous Harry Benjamin and to begin testosterone therapy. He's excited to scientifically bend biology to his will, and he is delighted at how easy it is to step into his own shoes, to be fully accepted as the charming, philandering man that he is. If this is possible, he wonders, what else could he do? This is Reed Erickson with his pet leopard, Henry. Just more examples of how cool he is. He also financed John C. Lilly's telepathic dolphin experiments, but we have to move on due to time. If you know anybody in Hollywood, do us all a favor and tell them to make a movie about Reed Erickson, okay? Reed Erickson starts a foundation. It's called the Erickson Educational Foundation. It is difficult to exaggerate the magnitude of the impact of the Erickson Educational Foundation in lifting up the cause of trans people. The foundation's goals, as stated, were these:
To provide assistance and support in areas where human potential is limited by adverse physical, mental, or social conditions, or where the scope of research is too new, controversial, or imaginative to receive traditionally oriented support.
What does the Erickson Educational Foundation actually do, though? Well, it opens offices in New York and San Francisco to offer referral packets, access to a network of affirming physicians, and crisis supports to anyone that asks. When pearl-clutching news stories about trans people are published in the press, Reed hires a team to answer those, to visit with traditional media and offer a counter-narrative. That works well, so he starts publishing a newsletter written in plain language for collecting stories on successful court battles and upcoming professional conferences. Reed publishes pamphlets on topics for physicians, such as an outline of medical management of the transsexual. Also, pamphlets for the public on topics such as how to update the gender designation on your driver's license. He organizes a trans awareness campaign that brings expert speakers and folks with lived experience to college campuses, police departments, law schools, and church socials. It awards seed grants to folks doing really good research. Reed funds the ACLU's Sexual Privacy Project. He funds professional conferences. Reed's money makes the Harry Benjamin International Gender Dysphoria Association possible. And just to clarify, the Erickson Educational Foundation was formed in 1964. The EEF became the responsibility of the Harry Benjamin International Gender Dysphoria Association in 1979. The Harry Benjamin International Gender Dysphoria Association changed its name to WPATH in 2007. EEF, the Benjamin Group, WPATH, they're the same group, essentially. Reed Erickson's personal wealth does something even greater than all this. It shepherds and funds the Johns Hopkins Gender Identity Clinic, the first institute of its kind in America. Suddenly, there's a clinic in America that's open for surgical business. Aside from Casablanca, Denmark, a couple other places, no surgeons are publicizing that they treat trans people with anything other than psychoanalysis. And now, all of a sudden, it's 1966. Johns Hopkins Gender Identity Clinic is open. Americans don't have to travel continents for medical care. And it's even under the auspices of a very reputable medical establishment. How exciting! Well, it's exciting if you happen to hear about it. The Johns Hopkins Gender Identity Clinic was operating more or less in secrecy, admitting very few patients, requiring tons of hoop jumping, and waiting for rigorous studies to prove that medical treatment of trans people would be helpful to society. In its first 6 years, the Hopkins Clinic received over 1,000 requests and treated about 24 people. Most doctors at the time are firmly against gender-affirming treatment. The prevailing view sees gender-affirming surgery like treating obsessive thoughts with amputation. So the Hopkins Clinic is very cautious, and the surgeons there are encouraged to have incredibly strict standards about which patients they will treat. Surgeons at these clinics routinely subjected candidates to humiliating evaluations, requiring them to prove their gender according to a doctor's subjective standards, sometimes in front of observers.
You say you feel like a woman?
Yes, I believe everything I do is feminine. I believe I'm a woman inside.
Oh, Michelle, how does it feel to be a woman?
It just feels like being me. Can't describe it as anything else.
You see, she's right. Nobody knows how anybody else feels inside.
Well, I believe I don't actually feel the way a normal man should feel.
Maybe that you identify with certain stereotypes of the female gender role, but that doesn't make you a woman.
A doctor's subjective attraction to you or belief that you pass as your gender could determine whether or not you receive medical care. You're required to perform your gender according to whatever hoops a particular doctor sets up to receive medical care, and thousands had to learn the hard way that they didn't qualify for that care. Remember what I said at the beginning? These practices weren't designed to help trans people. This is what they were designed to do: humiliate, gatekeep, protect the institution. And here's what's striking. By the early 1970s, even somebody at the absolute pinnacle of privilege still had to go abroad for care. One of Dr. Brew's most famous patients was Jan Morris. Prepare to be dazzled by somebody else you've never heard of. During World War II, she served her country as an intelligence officer. Post-war, she became an extraordinary journalist who produced the first irrefutable proof that during the 1956 Suez Crisis, the UK and France had colluded illegally with Israel in the invasion of Egypt. What a scoop. But don't worry, she had way more to do. Back before any human being had ever climbed the world's tallest peak, Jan was the only journalist embedded with Sir Edmund Hillary's expedition during the first successful ascent of Mount Everest. Jan Morris wrote many well-loved books and articles during her long life, many about her many travels and adventures out in the world and the fascinating people she met along the way. In 2008, The Times placed her among the top 15 British post-war writers. But doctors in Britain refused to provide her medical care because she didn't fit their criteria, because she was married. So, in 1972, she flew to Casablanca, met with Dr. Brew, paid her $2,000, and obtained her vaginoplasty. She courageously shared her journey in an interview with the BBC. Here she is, being asked about the medical transition she described in her autobiography, Conundrum.
Are you ever able sufficiently to stand back and see yourself and see a tiny element of absurdity in it?
No, I think it's beautiful. I can't think it's funny, because I think it's a truth that has been revealed. And I think it's a magical thing that's happened to me. And to have such a happiness and a fulfillment given to one halfway through life seems to be very unabsurd.
Here's someone at the absolute pinnacle of privilege. White, wealthy, educated, famous, respected, and even she has to travel to Morocco and pay out of pocket because the medical establishment won't help her. If that's true for acclaimed author Jan Morris in 1972, what does that tell you about access for everybody else? So by the early 70s, a handful of surgeons were helping trans people, mostly abroad, mostly expensively. Meanwhile, back in America, the clinic that had opened was about to be shut down. And then things got worse. Dr. John Mayer, psychoanalyst, is appointed chair of the Gender Identity Clinic at Johns Hopkins in 1969. The clinic's director asked Mayer to write a strongly worded paper outlining reasons for no longer performing transsexual surgery. In other words, Hopkins had decided to publish bad science in order to stop helping trans people. Mayer's infamously stupid study, published in 1979, measures things like post-op, how often do people move to a new address? Does their employment status change? He finds that people who had surgery still move addresses about as often as before surgery. Their educational level doesn't change, and neither does their employment security. Mayer concludes that surgery alone doesn't fix or improve trans people's social stability. In other words, surgery doesn't fix everything in your life, therefore surgery shouldn't be available. Notably, Mayer wasn't able to compare patients who obtained surgery with patients who dropped out of his research. For example, those who suffered the most from this denial of care, the suicides. Mayer's conclusion, which spearheads the end of gender identity clinics throughout the US, is this.
Surgery is not a proper treatment for a psychiatric disorder, and it's clear to me that these patients have severe psychological problems that don't go away following surgery.
It took surprisingly little evidence to shut down these clinics. It happened quickly, and once they were down for a very long time. Johns Hopkins didn't start treating trans folks again until 2017, 38 long years later, and 3 years after the transgender tipping point when actress Laverne Cox appeared on the cover of Time. One Jagoff's flawed study, and then kaput. That's institutional inertia in action, and we're still living with that aftermath. Thanks to magazine articles outing trans people and the Erickson Educational Foundation's work, trans people in the West were more aware than ever that they weren't truly alone. But how to meet others like you, how to access care when all you've ever read about are rich people, or at any rate, people who can save up thousands of dollars. Who do you turn to if you're the only trans person you know and you can't tell your family and your doctor has no idea what to do? This is the tiny town of Trinidad, Colorado, where Dr. Stanley Biber finds himself after the Korean War. He's hired to be the coal mining town's only surgeon. One day, a social worker he often consults with asks if he would help her obtain vaginoplasty. After asking, "What does transsexual mean?" he agrees. Dr. Biber calls Harry Benjamin, who tells him the social worker does meet his hormone requirements. Next, Dr. Biber writes to a colleague at Johns Hopkins to ask, "How do I perform vaginoplasty?" His colleague, and this is true, draws him a diagram and mails it back to Colorado. By all accounts, Dr. Biber's first vaginoplasty was not aesthetically pleasing, but it was better than nothing. His wife says, "He was the type of person who never judged anybody. He would take care of any patient. He'd forgive patients if they didn't have the money. That's the kind of person he was." For decades, this tiny town was known to those in the know as the sex change capital of the world. After 1980, Dr. Biber's tiny office was many trans people's only surgical option. It's a good thing he happened to treat them with kindness. At the same time clinics were closing in the US, something else was happening. The Harry Benjamin International Gender Dysphoria Association, remember originally funded by Reed Erickson? They created the first formal standards of care in 1979. Instead of each individual clinic or surgeon being on the hook to come up with their own standards for who should be able to receive what kind of medical treatment, including how passable the client must be in order to receive care, the Benjamin organization worked to create one standard that all providers should agree to abide by. The inaugural standards of care of 1979 are these. Patients must be diagnosed and assessed by 2 different doctors. Patients must have persistent gender dysphoria. That is, they must suffer distress that their gender doesn't match their assigned sex at birth. Patients' doctors must interview others in the patient's life in order to make sure they've had this dysphoria for at least 2 years. Patients must be living their correct gender in all areas of their life for months, no matter how physically dangerous or at risk of unemployment this makes them. Patients must receive psychoanalysis for months prior to having surgery. This becomes the gold standard for doctors to ensure that their patients have proven themselves worthy of treatment. But here's what's really important to understand. These standards weren't created to help trans people access care. They were created to protect doctors from liability, to make sure no surgeon could be sued. Remember criminal mayhem, that felony charge for disfiguring a body? Because they could point to months of therapy, multiple doctor evaluations, proof of persistent dysphoria. That's the world we inherited, not designed by scientific gods, but created by people protecting their careers. And we're still living with some of these ideas, even though the standards have changed significantly. So that's your history. That's how we got here. Pioneers proving it was possible. Magnus Hirschfeld and Harry Benjamin prescribing novel treatments. Christine Jorgensen sharing her story with the world. Reed Erickson trying to build infrastructure and influence media. Johns Hopkins opening with promise but delivering humiliation. Meyer at Johns Hopkins shutting it all down with bad science. Dr. Biber doing his best in a small town, and standards created to protect providers, not patients. Now let's talk about what these standards actually say today and how they've evolved. Before we get into what you as a counselor are required to look for before signing off that your client is ready for surgery, let's start here. How much information do you need before you believe someone when they say, "This is who I am, this is what I need"? Let's watch a clip from an anonymous documentary, Queens at Heart, made in 1967, 2 years before the moon landing and 15 years after Christine Jorgensen's famous penectomy. You'll see an interviewer, Jay Martin, ask questions of a woman named Vicky. These are very similar questions to those that used to be asked of transgender surgical candidates. Some counselors and psychiatrists still ask questions like these. They're generally called the "tell me your gender journey" part of the interview. Some counselors are kinder about it, and some, I believe, ask more because they're curious than because it's helpful to the client. It's your office. You can ask people whatever questions you'd like.
Vicky, you say you're engaged. What does your fiancé do?
He's a photographer.
Is he homosexual or is he straight?
No, he's straight, masculine.
Let me ask you this question. If he's masculine, wouldn't it be more normal for him to go out with a girl?
True, but I'm the nearest thing to a girl and I'm going for a change. And
When you say you're going for a change, you're going to have an operation.
yes.
Now, several of the other people we've interviewed are going to have the operation. Tell me something about it from your standpoint.
Well, it's a step away from loneliness and suicide because most of the homosexuals and drag queens, they get to a certain age and they don't want to live no more. So I've just about hit that age.
Have you ever felt that you wanted to end your life?
Oh, many times. And I just think about changing to a woman, hoping that would be an escape.
When did you first feel that you were not part of the world around you?
Oh, 14, 15.
Had you been effeminate in school?
Yes, I was an outsider.
Were you the butt of jokes and barbs from the other children?
Yes.
What would they say?
There goes the fairy, there goes Little Miss Wonder.
And this upset you?
Yes.
Was there anybody in those early days that you could talk to and tell about how you felt?
No, not until just about a year ago. I met people like me. I thought I was the only one.
Here's what's wild. The tell me your gender journey, that hasn't been required by WPATH for years now. We're asking because we're anxious, or because we were taught we should, or because we think we need to know somebody's childhood to determine if they're trans enough. But we don't ask 15-year-old cis girls looking for breast augmentation, much less balding South Africans seeking hair transplants, to prove they've always felt that way. We don't require cis people at all to explain their gender journey in order for them to receive gender-affirming surgery. So why treat trans and gender-diverse surgical candidates any differently? To recap, the first era of gender identity clinics opens in 1966 and closes around 1979. At the same time, the Harry Benjamin International Gender Dysphoria Association arrives on the scene with a regimented standard of care. Although the hope was that the Benjamin Group standards of care would align all care providers with one common standard, that's not exactly the outcome. All surgeons today have the ability to choose not to work with certain patients. All counselors have the same ability to refer out clients to other providers. At this moment in time, most surgeons abide by WPATH's rules, at least for adults. So do many counselors. But WPATH standards aren't laws and no one has to agree with them. You can make up your own rules or you can follow WPATH's. The standards have been updated several times since 1979, but the overall direction has been consistent. Less gatekeeping, more trust, more autonomy for the patient. Let me walk you through where we are now as of September 2022 and how it compares to where we started. These are WPATH's current standards of care's requirements for a counselor's assessment of a client seeking surgery. 1. There is no longer the requirement that the surgical candidate must suffer the distress of gender dysphoria. Instead, the provider must find that regardless of the presence or absence of distress, the surgical candidate must live with gender incongruence. 2. The provider must note any concurrent conditions. In the 7th standards of care, the old one, the coexisting conditions needed to be well controlled. Now, part of informed consent includes considering whether any coexisting conditions may negatively impact the outcome of gender-affirming medical care. 3. The provider must assess the surgical candidate's ability to provide informed consent for surgery. This includes discussing reproductive options. In the 2010s, folks seeking bottom or genital surgery were encouraged to take HRT continuously for 1 year prior to surgery. Now, if a person is looking to remove the testes or ovaries, their provider must note that the candidate has either been taking HRT continuously for 6 months, or that hormones are contraindicated for a medical reason, for instance that the person's levels are too high, or because the person is not interested in the effects of taking hormones. The other changes between the 2010 standard of care and the current standard of care are that A, there is no longer any expectation that anyone be living full-time as themselves for any length of time prior to surgery. B, a doctor's second opinion is no longer required and only one letter is ever required. And C, WPATH now clearly states that healthcare professionals should not make it mandatory for transgender and gender-diverse people to undergo psychotherapy prior to the initiation of gender-affirming medical care. Compare that to the 1979 standards. Back then, 2 doctors had to agree. Others in the patient's life had to be interviewed to confirm 2 years of dysphoria. Months of living full-time as yourself were required regardless of safety. Months of counseling were mandatory. And you had to be suffering. Dysphoria, meaning distress, was the price of admission. Now, 1 letter, not 2. No requirement to live as yourself for any length of time. No obligatory therapy. And you don't have to be suffering. Gender incongruence, not dysphoria, is the criteria. The system has moved substantially toward trusting trans people to know who they are. But let's think about this criteria for a moment. Does it make sense? Do you agree with it? Do you want to follow the current standard of care, or would you like to add anything to it or subtract anything from it? Let's check in around what we'll need to include in a letter that does follow current standards of care. First, we'll need to make sure that the person is in fact dealing with gender incongruence. Again, not all trans and gender diverse people suffer from the distress or discomfort of gender dysphoria. That diagnosis is no longer required. A history of marked and sustained gender incongruence is required. Familiarize yourself with the ICD-11's criteria for gender incongruence, which is defined this way.
A marked and persistent incongruence between the individual's experienced gender and the assigned sex. This often leads to a desire to live and be accepted as a person of the experienced gender.
I don't know, based on this definition, that being trans or gender diverse isn't just synonymous with having gender incongruence. Do we need to perform a specific assessment to gauge whether or not a particular client meets criteria for gender incongruence? According to WPATH, psychometric assessment tools are not a required part of the assessment. So the 2 diagnostic questions that I ask in order to make sure clients meet the criteria for gender incongruence are these. Number 1, are you trans? Number 2, do you have any worry or concern that you might be cisgender? If they answer yes and no, in my mind, they meet criteria for gender incongruence. So now that we've asked about diagnosis, we can cross 1 item off this list. Item number 2, how do you assess for comorbid, concurrent, coexisting conditions? Remember, you're not a doctor, so no need to go hunting here for family history of certain cancers or something like that. You're not here to assess or address physical health issues at all. As you would with any other client, most counselors generally start by asking a little bit about the surgical candidate's history. You could ask, do you have any mental health struggles that impact your day-to-day life? Do you worry that these might get worse if you have this surgery? If your patient says no, you can believe them. If they tell you they do have a condition that could negatively impact the outcome of surgery, for instance, maybe they're concerned they might become more depressed during the long, boring, painful recovery period, then you'll want to talk to them about that and help them figure out next steps. Maybe they prefer to address their depression before surgery, which even after you deliver your letter will likely be months away. Maybe they'd like to have surgery ASAP and consider seeing a prescriber to help with their depression. Maybe they'd like help finding a regular counselor. Maybe not. On the other hand, some counselors ask for a candidate's prior therapist contact information so they can double check that the information the candidate provides is factual.
Do they really have depression? Do you think they're ready for surgery, colleague? Let's consult.
Others may want to speak to the person's PCP. Some speak to both prior therapist and the current PCP, and also require more formal history taking, maybe some psychometric assessments. None of that's actually required. The reason that some counselors want extra information about a client who's come to them specifically just for a letter, not for ongoing therapy, is for their own peace of mind, to make sure the candidate is being honest with them and unlikely to sue after surgery. Ask yourself if you need to take those steps, and if you do need to take those, consider just communicating that to the candidate prior to the appointment. If a surgical candidate, whether dealing with mental illness or not, is unable to understand the risks of their chosen surgery, that's when it's really important to hit the pause button. This is rare. It's not necessary that their symptoms be completely in the past in order to consent to treatment, but you may need to work with some people over a series of sessions, or maybe find alternate ways of communicating with them, until they do understand that their chosen surgery may lead to complications, will require follow-up appointments, and will affect their body's processes. Informed consent extends to folks dealing with psychosis and personality disorders as well. No mental health diagnosis, according to WPATH, precludes gender-affirming surgery. So if a client tells you they're hearing voices or have been diagnosed with BPD, note that. Ask if they're concerned that such a coexisting condition might negatively impact their recovery from surgery. Talk to them about it. If you're unfamiliar or uncomfortable with these kind of diagnoses, you might just want to communicate that prior to the assessment appointment, just to avoid wasting the candidate's time and yours. Ultimately, it's not up to us to decide if a person is a good candidate for surgery. It's up to us to ensure that that person is able to consent to surgery. So that's what we'll do. We'll assess a person's readiness for surgery and their ability to give their informed consent for surgery. You're not here to understand or reiterate the medical details of your client's surgery. That's the surgeon's job. Surgical offices will go over every detail of the procedure and ask the candidate to sign that they understand. You're assessing something simpler. Does this person understand there are risks to having surgery, and do they confirm that they have an aftercare plan? How do you assess that? You can ask your client to read over the risks and benefits of their chosen surgery. Both WPATH Standards of Care and UCSF's Overview of Trans Medical Care are free, online, and make great homework. And then you can ask, do you understand the risks and benefits? Why do you want this surgery? What do you think will happen to your body? Have you thought about complications? Part of informed consent is also asking about fertility. Many gender-affirming interventions, including surgeries, can impact reproductive function, and some people aren't aware of this. A 2020 study showed that the majority of trans people questions wanted the option of having bio-kids at some time in the future. A separate 2020 study by Nina Weiss et al. Showed that consultation with a fertility specialist may help reduce regret related to this specific decision. It's worth knowing that fertility preservation is wildly expensive and usually not covered by insurance. So for many of your clients, this will be a very brief and maybe sad conversation, but it's an important one to have. At the very least, ask, are you aware that this surgery will restrict your ability to have bio-kids? Is that important to you now? Do you wonder if it'll be important in the future? Have you considered banking? Would you like to set up an appointment with a fertility specialist? Are you interested in resources around this or not? This is the difference between gatekeeping and good clinical care. Gatekeeping says, prove to me you're sure about this. Good care says, do you want to consider this? Here's information if you would like it. While we're in a position to talk to surgical candidates, it's either up to us to ask our client to read over the risks and benefits of surgery and to tell us whether or not they understand those, or to go a little more in depth. If you'd like to offer a little more, this would be a great time to encourage clients to prepare a million questions for their surgeon, to tell folks they are absolutely allowed to ask for before and after photos, and also to offer information inside our scope of practice as we can. Part of assessing for informed consent is asking the surgical candidate about how they plan on handling the recovery period. The WPATH Standards of Care don't require counselors to ask about this, but many surgeons right now will require this to be part of the letter. If a client doesn't want to talk about that, that's okay. An aftercare plan is just what it sounds like. We can just ask surgical candidates, how are you planning on getting your needs met while you're on bed rest? If they haven't thought about this yet, we can ask if they'd like help figuring this part of it out. For instance, in almost all cases, patients will need someone to drive them to and from their appointment. A medical cab is a good plan for some people, and for those with supportive community, a better plan might be to ask a particular friend or family member if they can count on them for this. Another thing to consider is that some surgeons will require folks getting bottom surgery to temporarily stay near the office for a little while, or will mandate staying in a specific aftercare facility. If having top surgery, patients will be on bed rest for some time and then for several weeks will be discouraged from lifting anything over 5 pounds over their heart. Depending on their source of income and lifestyle, this will be more difficult for some people than others. Ask your client, are you able to take time off work for this? Who can help you with getting meals or helping you with hygiene tasks such as dealing with drains? Some clients may appreciate having a chance to talk with you about how they'll get their emotional needs taken care of post-surgery, or if they'd like referrals to local affirming counselors. Others will not appreciate the condescension of having a stranger ask about that. Some surgical facilities offer counselors the option to fill in the blanks of a form rather than write a whole letter. The Transgender Health Program at Oregon Health and Science University's form looks like this. Which procedure is your client looking for? When did you meet with them? Are they taking hormones? What meds are they taking? Do they smoke? Do they have housing? I really like this question. Does this recovery environment include access to a clean and private bathroom? Does the recovery environment have stairs to access the living space or stairs within the living space that could create barriers to recovery? Having stairs or not having a private bathroom, those aren't deal breakers. But for people that do have the option to make their space easier to navigate, maybe check in with them about this. Middle of page 2. Does this client have the capacity to give informed consent for surgery? There's no room to explain your rationale. You just type yes or no. Middle of page 3. Please indicate by checking each box below that you've discussed these issues to your and your client's satisfaction. Potential changes in sexual functioning, risks and benefits of surgery and alternatives to surgery, the importance of aftercare related to post-operative complications and aesthetic outcomes. They're just asking you to check a box. So we did it. We ensured that our surgical candidate is in fact dealing with gender incongruence. We've checked in around any comorbid conditions, and we found that our client does indeed have the capacity to give their informed consent for surgery. Fantastic! Here's some ways we could ask a surgical candidate about their gender-related goals. We can ask, what are your gender-related goals? We can say that HRT isn't required prior to surgery, but many surgeons would like to know if you're on it, and how long you've been taking it continuously. What would you like me to put down? This can be a great opportunity to offer resources to folks who might not know how to go about fulfilling their goals. We can tell them about how extremely easy and affordable it is to obtain HRT from this clinic or that one. We can point them to other places that offer pro bono legal name changes, or we can show them where the DMV form for updating your gender marker is. This is also a great opportunity to just validate people's goals. Maybe they're looking for breast augmentation or rhinoplasty and are nervous that some jerk is going to suggest they consider jawline contouring. How nice that we can just tell them, sounds like you know what's best for you. Maybe they're a eunuch and are looking for orchiectomy and don't feel HRT is right for them at all. We can say, great, glad you're making choices that are right for you. Just in case you need one, here's one of the templates I use when I do brief assessments for surgery. It's a pretty simple one. You could probably write a better one though. Try to see if you notice which part of WPATH standards of care I forgot to speak to in this letter. Here's a quick reminder of the current standards of care. Psych. Trick question. All of the standards of care have been spoken to in this one tiny letter. That's it. That's the letter. We're done with the how-to. Is this the kind of letter you have to write if you're going to write a letter? No. You're free to create your own template. And as you do this work, you'll likely encounter additional things that some insurance companies or surgeons require to be in these letters, even though WPATH doesn't require anything extra. As I said before, WPATH's aim was to make one set of standards that everyone agrees on, but not everyone ended up agreeing on the same standards. For example, the Crane Center does a really nice job clearly listing additional criteria that will make your letter more likely to be accepted on the first try. Not every surgeon's office provides this kind of detail. Sometimes you'll hear that your letter was denied either by the surgeon or the insurance company. It almost always means you just have to have another 5-minute conversation with your client to add a few things to their letter. Similarly, it's going to take some time for every surgeon and every insurance company to catch up with the new standards of care. That's okay. You or your client can just contact their office and ask what their requirements are. I asked Reddit's Ask Transgender community, what made your letter writing experience positive or frustrating? What do you wish more letter writers understood? I got dozens of responses. Let me share what I heard. This sounds obvious, but it happens constantly. Therapists misgender clients in the letter itself. One person told me, my trans therapist and my cis surgeon for top surgery both misgendered me. I had gotten the best letter of my life handed to me, and the first thing I noticed was that I was called a girl every single time. It still frustrates me months later. Another person said their therapist spelled their name wrong. So here's your first action item. Ask basic questions and show clients their letter. What's a compelling reason to not show clients their letter of support? I can't think of one. Here's something that genuinely shocked me. Some providers are routinely administering cognitive assessments before writing letters. One person described it this way. I had to do the repeat 3 words to me in 5 minutes, draw a clock at 15 past 11, word association test thing, like 3 to 5 pages long. Do you recognize what they're talking about? It's the mini-cog, the test you give to suspected stroke victims and folks suffering from dementia or traumatic brain injury. Here's what this person said about it. The test, in essence, is asking us if we're of sound mind to be making this drastic decision, making sure we aren't actively manic. But we've been asked that our entire lives. Are you sure you want to dress like that? Is that the name you went with? What if you change your mind? This isn't reversible, you know. It's unnecessary stress. We've already asked ourselves about this a million times, and it isn't required for many other major surgeries. They're right. It's not required by any state law. It's not required by WPATH. It's not required by insurance. Unless your client has just overthrown a sovereign nation with no follow-up plan, don't do this. If someone can explain the risks and benefits of surgery to you, they can consent. Even if they're dealing with a psychotic disorder or have recently suffered a stroke. You don't need them to prove their sanity with a dementia screening. Ugh, this one's really important. Listen to what this person said. Everyone I have contact with during the medical transition process has the power to take that piece from me. I don't feel like providers are always aware of the power imbalance this requirement creates between trans people and the medical system. I am at times afraid to be completely honest because that honesty could be weaponized and used to justify denying me the right to make decisions about my own body. If I mention that 4-year-old me loved pink, princesses, and only played with girls, is this provider going to doubt the validity of my identity? If I bring up that I'm autistic or have a BPD diagnosis, are they going to force me to attend therapy for weeks or months just to prove I'm sane enough? Every question feels like a quiet insistence that I justify my reality over and over again. Your client is sitting across from you, terrified that if they say the wrong thing, you're going to take away their access to medical care. That's the context we're operating in. And that's why it matters that we minimize gatekeeping, stick to what's actually required, which does not include their gender journey, communicate clearly that we're there to help, not to judge, and explain why we're asking the questions we're asking. One last thing. Don't withhold letters just because you think somebody needs more therapy first. Here's why. In many cases, the letter is just to get a consultation appointment, which might be months away. Then they go on a surgical wait list for, at minimum, several months after that. One person explained,
Sometimes a letter is needed just to make an appointment for a consultation, which may not be available for several months, and is only a prerequisite to then getting onto the surgical wait list of several more months, if not years. A therapist should not hold back the letter if it seems like someone will definitely benefit from the surgery, but would also benefit from having a few therapy sessions before the surgery itself, because more than likely they are going to have the time to do that.
So if you think someone will benefit from surgery and might benefit from a few therapy sessions first, write the letter and recommend the therapy. They'll have time. The exception, if someone genuinely can't consent right now, they don't understand the risks, they're in acute crisis, they can't plan for aftercare. In those cases, help them get to a place where they can consent, then write the letter. But I think you should process your childhood trauma first is not a reason to withhold a letter if the person can consent to surgery right now. At least according to WPATH, it's not. Let me end this section with what one person said about their best letter writing experience.
My psychiatrist, who wrote my second letter, only required the bare minimum required by the medical system. I showed up to one appointment, he asked me my name and why I was there. We spent a few minutes casually chatting, and then he had me the letter within a week. He understood that I was an adult who knew what I wanted, and there was no reason for him to get in my way.
That's the bar. Get the basics right and show clients their letter. Don't use cognitive tests unless there's actual evidence of cognitive impairment. Understand the power imbalance. Your client is afraid one wrong answer is going to cost them access to care. Don't withhold letters just because you think somebody will benefit from more therapy. They'll have time during the surgical wait anyway, if they want that. And remember, there's no reason for you to get in their way. We're just about done with this section, the meat and potatoes section about how to write an affirming letter for gender-affirming surgery. Notice how you feel. Are you bubbling with concerns and anxiety? Are you feeling more relaxed and ready? I'm going to start with some very common questions just to get them out of the way quickly. Please take a moment to put your question or comment in the chat. I'm sure we'd all appreciate seeing your thoughts. So the question is, aren't these kinds of surgeries experimental? Many legislative bodies believe they are. Let's look at definitions first. The APA defines an experimental procedure as an intervention or regimen that is still being evaluated for efficacy, safety, and acceptability. When I gave a version of this presentation in 2023, here's what I said. Gender-affirming medical care is endorsed by every major medical and mental health organization in the United States and internationally. That's still mostly the case. However, 2026 is teaming up to be the new 1979 of shitty years for the trans and gender diverse community. Let's hope it's not the new 1933. Among Donald Trump's first acts as a second-term president was an executive order declaring trans identity legally invalid. And a second executive order, days later, targeting gender-affirming care not just for minors, but specifically for anyone under the age of 19. Within weeks, major hospital systems began capitulating. The Centers for Medicaid and Medicare Services issued unenforceable memos pressuring federally funded hospitals to comply. Health and Human Services launched a tip line to report trans-affirming providers, and no actual law needed to have been broken. The administration called gender-affirming care child abuse, and medical providers criminal. By fall, a new rule was finalized. Starting July 2026, any provider of gender-affirming care loses eligibility for public service loan forgiveness. This means that every employee, doctors, counselors, social workers, lawyers, front desk staff, anyone working in an organization that affirms trans people risks student loan forgiveness they might have spent a decade earning. 3 separate lawsuits have been filed. It might not survive the courts, but the chilling effect is already here. In December 2025, the Center for Medicaid and Medicare Services proposed barring any hospital that offers gender-affirming care to youth from Medicaid entirely. HHS simultaneously opened federal investigations into major children's hospitals and publicly boasted that the threat alone had caused over 40 hospital systems to stop care. In February 2026, Dr. Oz, the miracle weight loss guy from the Oprah Winfrey Show, summoned the leaders of America's major medical organizations to his office. Most held their ground, but the American Society of Plastic Surgeons broke with the consensus, issuing a statement recommending surgeons delay all gender-affirming procedures until age 19. Their own gender surgery task force was not consulted. The statement was drafted in weeks at the request of a federal agency by a leadership that includes a president who has donated repeatedly to Donald Trump. HHS immediately cited statements as expert medical consensus and announced federal investigations into the country's largest LGBTQIA+ federally qualified health centers. The Federal Trade Commission launched an investigation into WPATH that WPATH leaders call a nod to stifle their free speech. In March 2026, Dr. Oz directed every state Medicaid agency to stop reimbursing gender-affirming care for minors entirely and declared that conversion-based psychotherapy should replace it. People with privilege have always protected their own financial and reputational well-being above the basic needs of the more marginalized. This is not new. History has seen it before, and history has judged it. Regardless of the fear-mongering of bigots and the public statements of cowards, the standards of care for transgender and gender-diverse people seeking medical treatment are not experimental. They are the standards of care for trans and gender-diverse people seeking medical treatment. The question is around liability. Lawsuits do happen, and they do have a chilling effect on providers, and yet, I don't know, if you've done your due diligence and asked your client if they want surgery, and they've answered yes, and you've recorded that, well, so say one of your clients comes to regret their surgery. It happens. Most TGD people who later regret surgery report that regret stems more from a lack of acceptance by others than by the effects of surgery alone. The rate of regret for robotic prostate surgery is 20%. The rate of regret for gastric banding is 20%. The rate of regret for having children is between 5 and 14%. The rate of regret for abortion is 5%. The rate of regret for total hip replacement surgery is 3%. The rate of regret for all trans surgeries is 1%, among the lowest regret rates of any elective surgical procedure or major life decision. We should listen to the experiences of people who detransition, and we should work for a more equitable world in which there's increased acceptance of non-cis bodies. Some voices in the field, and you've probably heard them, argue that counselors should go slow and do gender exploratory therapy before anyone accesses medical care, especially young people. The idea is that some people dealing with autism, trauma, or anxiety may have been misled by kids on TikTok to identify as trans when they actually are cis, and that going slow will minimize regret. One of my favorite academics, Florence Ashley, asks a lot of good questions here, including the key question: is there any evidence that gender exploratory therapy actually leads to better outcomes than gender-affirming approaches? So when someone says, we should go slow to prevent regret, ask yourself, prevent regret for whom? The 1 to 2% who might regret surgery, or the 98 to 99% who need care right now? Gender exploratory therapy prioritizes the remote possibility of future regret over the immediate certainty of suffering. Now that we know a little about what came before, let's consider Levi again. What would life have been for him 100 years ago? Would he have known any other trans people or read about them? Or would he have spent his whole life believing he was the only one? Would he have been able to cross-dress, and if so, would his family have deserted him, or would he have been jailed for that, or just publicly shamed for who he is? I'm so glad Levi grew up in the 21st century. I'm glad he's able to know himself. I'm glad he's able to access care. He's afforded so much more possibility of experience because of that. But there are still barriers. For one, he needs this letter. Well, let's be very clear. Whether or not he gets the help he needs from someone like us, he's going to find resources. The quality of those resources still greatly depends on where you're born and how much capital you were born with, which has always been true. But today, Levi also has the internet. If his family doctor denies him HRT, he can buy it online from the Czech Republic or Turkey. If his counselor or surgeon or his insurance denies him access to medically necessary surgery, well, he could try to save up and go to Thailand, Mexico, or, weirdly, Iran. But before he tries other resources, he's trying for a letter first. He finds us online. He emails us. He asks for a one-time appointment. And what is he asking of us when he asks for a letter of recommendation for surgery? He's just asking us to see him and to believe him. We'll get back to the line chart in a couple of minutes. Back to the question we started with today. How much time do you need to have with somebody before you feel comfortable giving them a letter? Please indulge me for one more short video. This is a video that Levi made during COVID, and it's a record of his life so far. I think it's pretty good. Let's see him.
I guess I just got lost in being someone else. I tried to kill the pain, but nothing ever helped. I left myself behind somewhere along the way, hoping to come back around to find myself someday. Lately I'm so tired of waiting for you to say that it's okay. But tell me, please, will you one time just let me be myself so I can shine with my own light? Let me be myself. Would you let me be myself? I'll never see the light of day living in this cell. It's time to make my way into the world I knew, and then take back all of these times that I gave in to you. Lately I'm so tired of waiting for you to say that it's okay. Tell me, please, will you one time let me be myself so I can shine with my own light? Let me be myself for a while, if you don't mind. Let me be myself so I can shine with my own light. Let me be myself. That's all I've ever wanted from this world, is to let me be me. Please, would you one time let me be myself so I can shine with my own light? Let me be myself. Please, will you one time let me be myself so I can shine with my own light? Let me be myself for a while, if you don't mind. Let me be myself so I can shine with my own light. Let me be myself. Would you one time, ooh, let me be myself?
There is no substitute for feeling confident in your own skin and having a body that expresses who you are. Many things have changed since this photo was taken, but some things hold true timelessly. Living authentically is timeless. If this picture were taken yesterday, it would still contain the same felt sense of confidence and autonomy. Levi's story today echoes that trans joy you're seeing here. What a privilege to get to be in a profession where you get to see people as they are on their journey. What a gift that we get to meet with people on their way to becoming who they were meant to be. We all agree that all people deserve compassionate, competent care. We just need to figure out what constitutes that and hold ourselves accountable to it. In my opinion, compassionate, competent care is also timely. You've had a chance to explore some of the history of gender-affirming care here, and you've had some time to evaluate where you're at on this line chart. Maybe you're still at the same point you were at before. Maybe a few months or years feels like an appropriate amount of time to wait before offering a client a letter. But for some of you, I'm guessing you've moved somewhere on this line. I'm guessing some of you have maybe moved toward a shorter interval, not a longer one. Here's the thing, you're the expert on your own practice and your own boundaries and needs. But I do want to leave you with 2 action items, regardless of where you land on that line. 1. Check in with yourself. Are your requirements for a letter serving your client's needs or serving your own discomfort? If the honest answer is both, good job being aware of it, and authentic awareness is the first step toward conscious choice. 2. Be clear with clients about your process on your website in your first email replying to their ask. This is not about defending your choices. It's about helping people find the right provider for their needs. Transparency is a kindness. The positions we take here are going to have meaningful impacts on real people's lives. Where are you at? What do you think?
Harry!